Today I will be presenting a case on alcohol use disorder and fibromyalgia. Where is the overlap? Learning objectives. By the end of this 20-minute presentation, you should be able to outline the guideline recommendations for AUD treatment, outline the guideline recommendations for fibromyalgia treatment, and apply this knowledge and evidence in choosing appropriate overlap therapy for both conditions. My patient is a 31-year-old female who has been referred to our clinic for generalized body pain. Our clinic is a specialty clinic, and so she's been referred to us by her primary physician, and it's probably taken her about 20 months to get into our clinic. So in the meantime, she has been treated for several other conditions, including anxiety, gastritis, iron deficiency anemia, alcohol abuse with recent relapse. She says she is drinking a lot but is working on it, so she could not quantify the amount of alcohol that she's drinking. She has ADHD, fetal alcohol syndrome, problems with impulse control and anger, and was recently admitted to the PASU for a psychotic episode related to substance use disorder. And she reports having bugs all over, bleeding everywhere, and is often unable to sleep. Her social history includes alcohol use disorder. She's a smoker, smokes approximately 2 packs per month, and uses recreational drugs and marijuana. Of note, she is a mother of 2 and has just lost her youngest child to social services because of her alcohol use disorder, and she needs to be in remission before she gets custody of her daughter again. Her immunization status is unknown. She was unable to tell me this. The current medications my patient is on are nabilone 2 milligrams 3 times a day for harm reduction for her substance use disorder, acetaminophen 325 milligrams twice a day, Tylenol number 3 1 tablet twice a day for pain, risperidone 1.75 milligrams at bedtime for psychosis, stress ulcer prophylaxis. She is taking pantoprazole 40 milligrams daily. For her anxiety disorder, she's on clonazepam 0.5 milligrams twice a day. For her nightmares, she's on prazosin 9 milligrams at bedtime. And she also endorses that she has been purchasing gabapentin and diazepam off the street. Since our patients are currently not being seen in the clinic, this was a telephone interview, so I only really did have access to her labs. And again, the patient was on the move. Seems quite hyperactive, so she was on the move on her cell phone. I could hear city street sounds, etc. So she sometimes cut out. So she was alert and oriented. She could tell me her name, her birth date, and where she was. She responded to questions appropriately during the interview, and the only blood work of note was her hematology. So her hemoglobin was 84, hematocrit 0.29, her MCV 72, ferritin 3, and a month before her hemoglobin was 74. CC has several drug therapy problems. She's at risk for potentiation of respiratory depression secondary to the concurrent use of alcohol with prescribed Tylenol 3, nabilone, risperidone, and clonazepam, as well as non-prescribed gabapentin and diazepam, which she purchases off the street, and she may benefit from reassessment of the management of AUD in her drug therapy. CC is not on optimal therapies for her pain management and would benefit from reassessment of her drug therapy. Other DTPs include that she's not on optimal therapy for her chronic iron deficiency anemia and would benefit from reassessment of this therapy. She continues to experience anxiety and would benefit from reassessment of the medication she's on for the treatment of anxiety. And she is experiencing ongoing insomnia and would benefit from the reassessment of her therapy. The goals of therapy for CC are to primarily first, before we actually take her into our program, treat alcohol use disorder with the goal of harm reduction or abstinence. She would probably not reach abstinence currently, but this is the goal for getting her daughter back. Other goals include reducing pain, anxiety, and insomnia, utilizing harm reduction strategies to maintain communication and engagement in therapy, minimizing ADRs from drug therapies, enhancing compliance, and improving her quality of life. Her cost may not be an issue because she's on Persons with Disabilities and she does belong to First Nations, so is under First Nations Health Authority and has her medications covered. So beginning with DTP1, CC is at risk for potentiation of respiratory depression, overdose, and death secondary to the concurrent use of alcohol with prescribed Tylenol 3, Nabilone, Risperidone, and clonazepam, as well as the non-prescribed gabapentin and diazepam. Tools that I would have used for screening CC for other use disorders such as nicotine or substance use would have been obtained from the BC Centre for Substance Use, and the one that I would have used would have been probably the TAP screening score, the Tobacco, Alcohol, Prescription Medication, and Other Substance use tool. This one I didn't end up having to use because she's very forthcoming and did mention all the things that she was using. Alcohol use disorder is a chronic relapsing brain disorder characterized by an impaired ability to stop or control alcohol use despite adverse social, occupational, or health consequences, and it is considered a DSM-5 diagnosis. Safe drinking is for women considered to be less than 2 standard drinks per day, for men less than 3 standard drinks per day, and my patient, of course, drinks much more than this. Health conditions associated with AUD are depression, pancreatitis, high blood pressure, GI disorders, hepatitis, cirrhosis, gout, memory issues, anemia, anxiety, insomnia, cardiovascular disease, seizures, and psychosis. My patient suffers from several of these, including depression, memory loss, anemia, anxiety, insomnia, and psychosis. She did not endorse seizures. Alcohol use disorder is defined in the DSM-5 and includes 11 questions which allow for classification of severity. If 2 to 3 symptoms are defined, then it's mild alcohol use disorder. If there are 4 or 5 symptoms, then it's moderate. And if it's severe, there are more than 6 symptoms. Some of the questions include, have you had times when you ended up drinking more or longer than you intended? Have you spent a lot of time drinking or being sick or getting over other after effects? Have you had to drink much more than you once did to get the effect you want, or found that your usual number of drinks that had much less effect than before? I have divided my treatment plan for AUD into continuing care and to, of course, there is the treatment of withdrawal. The treatment of withdrawal would not be done within our clinic. So I had sort of decided to discuss the continuing care because this would fall within my scope and would also cover the fibromyalgia clinic scope. Continuing care of AUD, the first-line pharmacotherapy include naltrexone and acamprosate. The goals of both these treatments are either abstinence or reduction in drinking. Second-line therapy include gabapentin and topiramate. Continuing care also includes providing motivational interview-based counseling to support achievement of treatment goals, providing information about specialist-led psychosocial treatment interventions, and providing information about referrals to peer support groups and other recovery-oriented services in the community. Our client has very good supports. She goes to a clinic here in Vancouver called Sheway Clinic. It's for women, and it's got a team of physicians, RNs, social workers. She's also on daily dispense. So generally setting these additional treatment intervention centers and recovery services is not that critical for her because she does have access to this in her current living situation. So once again, the BC CSU guidelines on continuing care suggest naltrexone and acamprosate as first-line treatments for the treatment of AUD, and with the goal of abstinence or decrease in drinking. Other treatments include gabapentin or topiramate as alternatives, and these are based on patient preference or if there are any contraindications to using the other medications. And again, motivational interviewing should be offered to all patients with mild to severe AUD to support their treatment goals of either abstinence or decrease in heavy drinking. I've just included the pharmacotherapy charts that are provided by the BCCSU. They're very useful and go over the different choices that one has, what one should consider when choosing a drug, caution, side effects, coverage and cost, safety and other considerations, and of course the dosing. Guidelines are also provided for outpatient management of alcohol withdrawal, and here are similar charts for how to implement the use of either benzodiazepines, carbamazepine, gabapentin, clonidine, depending on the patient, either preference, contraindications, and cautions, whether it be decreased renal function, whether they're breastfeeding, whether they have hypotension. So this is a very useful chart also from the BCCSU. The BCCSU guidelines use the PAUSE score to assess the risk of severity of the complications of alcohol withdrawal in patients with alcohol use disorder. So they divide patients into low risk, severe risk, and low risk patients can be treated as outpatients, and those with severe risk would be treated as inpatients. From my patient, who is a very strong personality, I became aware that she would not do inpatient therapy. She is in a clinic that has incredibly strong supports. So if she were to embark on alcohol withdrawal treatment, she would probably do it as an outpatient, and she would have the support she would need at the Sheway Clinic. So back to my patient, CC, looking at the charts that I was provided with through the BCCSU, the therapeutic alternatives would be naltrexone, acamprosate, gabapentin, or topiramate. Now, based on patient preference, she refused naltrexone and acamprosate. She's very strong in her choices and decisions, and she would not take them. She absolutely refused. Topiramate would probably not be a good choice for her because she does have psychosis, and topiramate is known to cause psychomotor slowing, difficulty in concentrating, speech and language problems, fatigue and mood disturbances, and also potentially psychosis, so it would not be a good choice for her. So the last alternative was, of course, gabapentin, and that is her drug of choice. She is already buying it off the street, so now sort of formalizing that and having her take it regularly and not having to purchase it would probably be a good idea. Gabapentin is also useful because it is used for other disorders. So, for example, neuropathic pain, restless leg syndrome, insomnia, and she has insomnia and neuropathic pain. So it does sort of cover those bases. Another reason for the use of gabapentin would be that if she were going through alcohol withdrawal, so I feel that she was in fact going through withdrawal from alcohol before we spoke, and this is probably why she was buying the gabapentin and diazepam, and she was probably kind of treating herself that way. So I think gabapentin would be a good choice for her. Gabapentin does not have Health Canada approval for the use of in alcohol use withdrawal. So the only two that do have them is naltrexone and acamprosate, and of course there was disulfiram. I haven't seen it used in the BCCSU guidelines. So I did want to check what the evidence was for gabapentin. So I did a search. I searched Medline and Embase for alcohol use disorder and compared gabapentin with placebo and its effects on alcohol consumption. So those were my search terms: alcohol use disorder treatment. There were quite a few trials, so I looked for RCTs in humans and in English. And I ended up picking a meta-analysis, actually, that looked at 7 studies, and the meta-analysis was called Studies of the Efficacy of Gabapentin for the Treating Alcohol Use Disorder. The study that the meta-analysis that I looked at was a placebo-controlled randomized controlled trials. It had a sample size range from 21 to 338 participants. Most of them were males, most of them European ancestry, and it compared gabapentin to placebo. So gabapentin, a dose of 300 to 3,600 milligrams a day, duration varied from 3 to 26 weeks, and the primary endpoint was abstinence, relapse to heavy drinking, percent abstinent days, percent high drinking days, and GGT. The results showed the outcomes that they looked at, which were 6 different outcomes: complete abstinence, relapse in heavy drinking days, percent days abstinent, percent heavy drinking days, drinks per day, GDT concentration. And the only result that had statistical significance was the percent of heavy drinking days, where there was a decrease in the percent of heavy drinking days. So the strengths of this meta-analysis I found were that it was the first meta-analysis that examined the efficacy of using gabapentin for the treatment of alcohol use disorder. It had roughly 482 participants, and it had 6 outcome evaluated. It was a minimum of 4 studies that contributed to each of the 6 outcome measures, and they tested 3 potential moderators of heterogeneity of effect size: study completion rate, gabapentin dosage, and study duration. The limitations of a meta-analysis, of course, is that it lacks homogeneity in some of the outcome measures. So, there's a range, as you see that there's, in some studies there were 31 patients, in others there were several hundred. So there's quite a wide range. In some studies, the sample size could be too small, and the small number of studies limit the statistical power. And of course, one does have to keep in mind that exclusion of studies that show no effect are not included, and so it doesn't help show the statistical significance. The summary of the study, however, showed that in patients with AUD on gabapentin compared with placebo, there was a significant increase in the number of people with reduced heavy drinking days. And the dose that they were looking at was up to 1,200 milligrams per day versus placebo. And it showed that gabapentin might be most efficacious in people with alcohol use disorder and a history of alcohol withdrawal symptoms, relapse-related symptoms of insomnia, dysphoria, and craving, and it generally has a very good safety profile. So in my case, the choice of gabapentin was probably a good one, because I think that my patient is experiencing already some withdrawal symptoms. She does suffer from insomnia. She has dysphoria, and so I think that this is a good choice, and so that would be one of my recommendations. DTP2. CC is not on optimal therapies for her pain management and would benefit from the reassessment of her therapy. She's taking the following for pain: acetaminophen 325 milligrams twice a day, Tylenol 3, 1 tablet twice a day, gabapentin, as mentioned, not prescribed, and alcohol. As mentioned, CC was referred to our clinic for the treatment of her fibromyalgia. Fibromyalgia is a condition that comes and goes. It is defined by pain that has been present for at least 3 months, and it seems to be generalized all over. It belongs to a class of centralized sensitization syndromes, which include IBS, migraines, temporomandibular joint disease, PTSD, So there's a whole bunch of different syndromes that fall under this category, and fibromyalgia is a big part of this. Historically, the diagnosis of fibromyalgia has been very difficult. In the past, it took decades for patients to be diagnosed with fibromyalgia, so they'd often go to different doctors. Some people will even describe how they have been sort of not taken seriously and have gone from doctor to doctor. They've tried opioids. Many are still taking opioids because they've never been able to get off of them. So the guidelines now suggest not doing comprehensive testing and using the criteria that if you've had generalized pain for more than 3 months, then you should be treated as if you have fibromyalgia. So there is no diagnostic criteria that is required to confirm a clinical diagnosis of fibromyalgia. This diagnostic chart is used to diagnose fibromyalgia, and when there's pain in 4 to 5 different regions that are identified, and if the patient has had pain for at least 3 months, then they are considered to have fibromyalgia. They often have concurrent diagnoses such as fatigue, trouble thinking or remembering, waking up tired, having pain or cramps in the abdomen, so IBS is often diagnosed, depression or headaches. For this case, I went and I looked at a few different guidelines for the treatment of fibromyalgia. So the Canadian guidelines suggest starting in the step-up analgesic ladder, and they do start with acetaminophen and NSAIDs. However, most other guidelines don't really recommend acetaminophen and NSAIDs for the treatment of fibromyalgia because they don't really seem to work for many people. As adjuncts, they sometimes work, but not often. Further up the ladder, the Canadian guidelines recommend antidepressants, including TCAs, SSRIs, SNRIs, and anticonvulsants. So I will go through some of the different choices a little later. Next, I looked at the EULAR guidelines. These are the European guidelines. They suggest the use also of TCAs, duloxetine. Tramadol is mentioned as well. Tramadol can be used in our clinic. We try to refrain from using it. And then pregabalin, cyclobenzaprine are also recommended. Another European guideline from the European Network on Myalgic Encephalomyelitis and Chronic Fatigue Syndrome, EuroMEAN, suggests also the use starting with paracetamol, so that's acetaminophen and NSAIDs for short periods of time, up to 7 days, but really they don't bank on those drugs. They go with gabapentin, tricyclic antidepressants. Low-dose naltrexone is also another choice that is becoming more and more common. Duloxetine, venlafaxine for pain. Back to my patient. The choices that would be alternatives for her would be duloxetine, venlafaxine, gabapentin, and topiramate. She did not want to use venlafaxine, so we had to move away from that as a choice. She was already on gabapentin, or that was the suggestion made for the treatment of alcohol use disorder, and although the maximum dose for fibromyalgia is much higher than alcohol use disorder, we didn't feel it would be a good choice to go up to the 3,600 milligrams just because if she was still drinking alcohol, etc., this potentiation would not be beneficial. Topiramate, again, we decided that this would not be a good choice for her for the same reasons that we didn't use it for alcohol use disorder. She has had psychosis, and this could exacerbate that. She also has difficulty concentrating already, speech and language issues, somnolence, fatigue, and mood disturbances. So we decided against this. So one choice would be duloxetine for our patient, simply because she also suffers from anxiety disorder as well, and so this could be useful for treating her anxiety. She's on clonazepam for that, and then if we were able to stabilize her on duloxetine, we might be able to get her off of the clonazepam as well. So that was one reason. So before making the decision, I wanted to go back to my patient and discuss some of the considerations. So be realistic about the outcomes. Treatment focuses on active patient participation towards achieving health related goals and incorporating non-pharmacological methods. That's really the basics of the treatment of fibromyalgia, and we say myalgic encephalopathy, chronic fatigue syndrome, and fibromyalgia, so the sensitivity syndromes. And so most of our clients will go to things like pacing, they'll go to courses on diet, etc. And so it's very important that this participation can occur with our client as well. And really those skills that are taught, mindfulness, etc., are very critical in the treatment of these syndromes. In fact, they're more important than the pharmacological therapy. And so we know that the drug therapy will not bring significant pain reduction, or even that it will relieve pain completely. So, the most that we can hope for is roughly 30% decrease in pain. The other considerations would be to evaluate her other conditions and medications. So first of all, before embarking on the duloxetine idea for therapy, we wanted to really explore whether she has bipolar disease. She talks a lot about, she herself says, I've been told not to take antidepressants, and it's unclear where she's got that from. We know that she's been admitted several times for psychosis, and her primary physicians assure that this is related to substance use disorder and not to mania or like bipolar disease. So that would be one of the things to really monitor for. And then the other question would be, can we discontinue nabilone, which again contributes to psychosis. She also supposedly is registered to take medicinal marijuana, and she does take marijuana off the street. So these all contribute to her psychoses. And the patient continues to suffer from pain, anxiety, and sleep disturbance. So she has very fixed ideas about what she has tried and how it works. For example, the iron, if I did mention to her she should consider taking iron, and then she goes off tangentially that she's taken iron and she bleeds all over and there's blood all over the floor, and it's people are trying to kill her. So she and she's also quite clear that she took duloxetine once and it made her psychotic. So again, trying to tease out what's real and what's not real, simply because there's some elements of truth in what she says, and then some elements of the psychosis. So coming back to my patient, I did finally decide on the gabapentin. So we started gabapentin 300 milligrams 3 times a day, and we did initiate alcohol withdrawal management, which included thiamine, folic acid, fluid electrolyte replacement, and she was on clonidine. And as mentioned, she does go to a daily dispense clinic, and they're very, very good there. So they would dispense the clonidine to her as she needed. We also insisted that she be treated for her alcohol withdrawal before alcohol use prior to actually committing to being in our programs, just because participation is very, very important. So if the alcohol use has not been resolved, then it's very difficult to take in a patient like this. Again, gabapentin was due to patient preference. It was used to overlap treatment of her other illnesses, such as anxiety, withdrawal, and pain. She has no cost concerns. She has PWD and is covered through First Nations Health Authority. Medication will be daily dispensed, so there is no risk of diversion, and she will not purchase medication from the street. With regard to her second drug therapy problem, the recommendation would be to start her on duloxetine 30 milligrams daily for 2 weeks. Once AUD therapy has begun, titrate to a target of 60 milligrams daily, but first monitoring 2 weeks later as to whether she's tolerating, and monitoring very closely for psychosis. The rationale for this choice was that the patient is suffering from pain, anxiety, and possible depression. So again, rule out bipolar disease. Patient has substance use-related psychosis. The CCP guidelines recommend the use of duloxetine for the treatment of GAD. Also, the Canadian Rheumatology Association, EULAR, and the European Network guidelines suggest the use of duloxetine for the treatment of fibromyalgia. She does have an interaction, which would be the duloxetine-risperidone interaction, so there could be a 2.5-fold increase in risperidone levels. Her dose right now is 1.75 milligrams, a very odd dose, but if that was the case, then it might take her up to about 4 to 5 milligrams, and the maximum dose for risperidone is 8 milligrams. So we would have to really watch for mental status changes, vital signs, dyslipidemia, EPS, and dystonia. And in the future, once her AUD is under control, if that ever would be, consideration should be given to smoking cessation, as smoking can enhance pain. So when I was speaking to CC, I did explain to her that we would like to implement some change in her drug therapy, that it would be better for us to start her on gabapentin and help her to manage her alcohol use, because her goal is to get her daughter back, and this is only possible if she is abstinent. And so the first step in that goal would be to decrease the amount that she's drinking, and to that end, and to stop her from having to purchase gabapentin off the street, one alternative would be to start regular gabapentin. And also with regard to the multiple medications that she's taking for her to manage her pain, so a lot of it is pain related. I explained to her how this was affecting her CNS, her respiratory depression, that it may affect the way she breathes, and it is a risk for overdose and death. And she was aware of this. She understood, and she was very motivated to try and go through the alcohol use withdrawal therapy. So we did underscore. So I told her I was going to be talking to her primary care physician, and she and her nurses there at the clinic that she's at. And so all of them were actually on board, as was the pharmacist. So I think she felt that she was in good hands. In terms of monitoring for her alcohol use with disorder as well as fibromyalgia, so first we want to note a decrease in heavy drinking, improvement of pain, improvement in sleep, improvement in anxiety. When would we do this? Every day, patient, pharmacist, MD. So this sounds like a lot, but she does have access to the pharmacist every single day. She has access to the physician and the nurses at the clinic every single day. And then in terms of safety, to look at her CNS responses, ataxia, slurred speech, and drowsiness. Anytime, again, MD, pharmacist, nurse, and patient, and the expected change would be the presence of those would indicate, toxicity. And then again, to look for worsening of her depression or behavior or psychosis to ensure that she is not bipolar. And this would be, again, any time within the first 2 weeks, MD, nurse, pharmacist, patient. So this would be my monitoring plan. And finally, looking at what happened in terms of the follow-up, her Shiwei physician, primary physician, accepted the recommendation. I did go into her pharmanet 2 weeks after I had talked to her, and then I did notice that she had been prescribed the withdrawal medications, clonidine, etc. She was started on duloxetine. She is doing well, and there is going to be a further follow-up in 2 weeks. If you have any questions now, I'd be happy to answer them, and thank you very much for listening to my presentation.